Okay. Hi, I'd like to welcome everyone to our live Facebook chat today. This is brought to you by the Ottawa Birth and Wellness Centre, a collaboration between the Ottawa Birth and Wellness Centre and Women's Mental Health at the Royal. Today, we're lucky to have Dr. Gandhi, who is a staff psychiatrist at the Ottawa Hospital and assistant professor at the University of Ottawa. Dr. Gandhi has established the Perinatal Mental Health Program at the Ottawa Hospital in 2007 to address the mental health needs of pregnant and postpartum women in the capital region. Her academic focus is on medical education in women's mental health, consult liaison psychiatry, and interpersonal psychotherapy. Currently, she is working with her team and regional partners on a transition to virtual care and enhanced support for mothers during the COVID-19 pandemic. Dr. Gandhi is the proud mother of 2 teenagers, and her first child was born during the 2003 SARS epidemic in Toronto. Thank you for joining us, Dr. Gandhi.
Thanks so much, Nancy, and thanks to the Royal and thanks to the Ottawa Birth and Wellness Centre for making the time to have me today. I really appreciate it. And I know we have Stephanie in the background from the Ottawa Birth and Wellness Centre giving us the IT support, so many thanks to her. As per my introduction, my first son was actually born during SARS 2003 in Toronto, and so just want to send out a very big wave of empathy, if you will, to all the moms here, new moms that have been pregnant, are pregnant, or have recently had a baby. SARS was nothing what COVID has been, and so it's an extremely challenging time, and I just want to make sure that everybody is being very kind to themselves during this period, because it is quite stressful. And I will focus this discussion a little bit more on what to do if you think that you're experiencing signs and symptoms of depression and anxiety. What I'm hoping to do is speak a little bit more informally. I will, talk for a few minutes and then pause and ask Stephanie if there's any questions that you guys have typed into the live event. So feel free to ask away, and I'll do my best to answer your questions. So I think you heard earlier from earlier talks about what is depression, what is anxiety, what are the common mental illnesses that come up during pregnancy and the postpartum year. So when do those diseases or disorders, when do they get serious enough that it's important to actually seek treatment for them? So there's a few technical answers to that, and then there's a very practical answer to that. And I would say that the practical answer, which is what matters the most, is if you feel like your symptoms are getting in the way of your ability to function in a day-to-day manner, then they are worthy of attention. And we'll talk about who's the appropriate person to bring your concerns to. But really, that's the measure that we're always looking for. We all experience stress, especially in these days. And having a baby, even if it's the most joyous event in your life, is a stressful life change, no matter what. So differentiating normal stress, normal anxiety, normal mood shifts from shifts or changes in your well-being that actually coincide with something that needs treatment is something that is when you have something that interferes with your function. I apologize for my dog growling in the background. Hopefully she's actually very lovely, but there's a delivery person ringing the doorbell, and she's not used to people coming to the door, so I'm going to let her out. Excuse me for 2 seconds. All right, my apologies for that, the joys of live presentations. So if your function in terms of your ability to parent, in terms of your ability to do your job, or in terms of your capacity to sustain your relationships, whether that's your relationship with your significant other or your friends or your extended family. Those are all relevant parameters to watch out for when you're looking for active symptoms that might indicate that something stronger is afoot that you need to look into more. A technical way to decide whether or not your symptoms are a little bit more than outside of the normal range would be to do something called an Edinburgh Postnatal Depression Scale, or EPDS. So after the presentation, I'll try to find a link for you that we can post to the Facebook Live. But you can also Google EPDS, Edinburgh Postnatal Depression Scale. And this is a scale that you can do on your own. It's only 10 questions. It comes in many different languages. It's universally acceptable and it's free. The scores on those scales kind of give us an indication of whether or not you may be at risk for a depression or anxiety disorder during your pregnancy or postpartum period. So if your total score, and they have instructions at the bottom of the scale, if your total score is above 12, that indicates a positive screen, meaning that you could be at risk. If your score is greater than a 20, you're at even higher risk. It's not a diagnostic instrument, meaning that it's not going to tell you either way whether you have a depression or have an anxiety disorder, but it's going to tell you whether or not you're at risk. So the higher the score, the more risk you are that you are actually suffering from an active disease that needs intervention. And definitely anything over 12 indicates a positive screen. So that's a bit of a technical way to look at whether you might be suffering from something that needs treatment. I'll pause there and ask Stephanie if there's any questions at this point.
No questions at this moment.
Okay, perfect. Okay. Keep moving.
Yes.
So who can you approach if you are worried that you may have symptoms that need intervention? Well, first of all, I will highlight to you that if you are experiencing any thoughts of not wanting to live, any thoughts that you think you might not act upon, that life is not worth living, you're thinking of harming yourself, you sort of feel like that's quite imminent, that is an emergency, and that is a trip to the emergency room. Our emergency rooms across the city are safe. They are able to accommodate you, and definitely having suicidal ideation, as we call it, is a clinical emergency that needs appropriate intervention immediately. So do not hesitate to go into the hospital if you need to be treated. I know everybody is a little bit worried about that in the context of COVID-19. Another clinical emergency which deserves a trip to the emergency room is if you find that you're experiencing hallucinations. So hearing voices or seeing things that other people can't see or hear. That's worth a trip to the emergency room, because that could indicate an extremely serious level of illness where we need to intervene right away to maintain your safety and the safety of your family as well. Those would be the biggest examples of clinical concern, but I would say, you can always, the emergency room exists for people that are having health problems. And I just want to underscore that. The hospitals are doing an incredible job of infection control. And if you need clinical attention, that should definitely be on your list of options as places to go. There is also the crisis line in Ottawa, and that's another phone number that we can circulate on a live chat as well. So this is a 24/7 phone number that you can call to get support, again, at any time. And that's, where if you feel like you need somebody to talk you through a crisis, to, figure out if this is something that you need to be, to receive more intervention on, If you need somebody to help ground you in extreme anxiety, if you need somebody to help just talk through the frustrations of your anger or your isolation or any conflict that you might be having, this is an amazing resource that we're very, very lucky to have in our region. The crisis line is supported by trained people who man the phones and know when a situation might be of higher risk and warrant you coming into the emergency room or potentially even sending out emergency services to you. So those are for the higher risk population and for serious symptoms. Family Services of Ottawa is another great resource that I will point out to you. Family Services of Ontario has virtual clinics that they are still running, particularly for mothers. So they are running a support group for moms dealing with mental health issues. They are also running a virtual support group for moms who are experiencing anxiety in the COVID arena. So, highly suggest those community resources for you. I think the Ottawa Birth and Wellness Centre has done an amazing job of collating some of the resources that are on their website. So I will refer you to that as well. And the Royal Ottawa Hospital has also come up with an amazing resource list for women who are pregnant and in the postpartum phase. So refer you to all of those incredible resources. There is a lot that's being offered, and that's either free or quite affordable for you to start your journey. I'd also encourage you to speak to your family doctor, speak to your obstetric care provider, whether that's your midwife, your obstetrician, your family doctor, and also to speak to public health. So, we're hearing every day from public health when it comes to COVID-19, but public health remains the touchstone for seeing and assessing and supporting mothers in the community, in their homes, who may be struggling with various concerns, but also with mental health concerns. And they have different programs that you can access through public health. So your public health nurse, your midwife, your family doctor, your OB, definitely are all available to help you and help guide you in the right directions. I'll pause there again because I've listed a lot of resources without phone numbers or and the promise to follow up on that, but I'll just see if there's any other questions at this point.
There's no questions, but I'm totally taking note of all the things that you're mentioning, so we'll add them into the comments after.
Terrific.
And so I just thought, since you're talking about resources, Dr. Gandhi, I would point out the C-Prompt clinic at the Royal, which is an urgent mental health care clinic. It does need a referral from your healthcare provider. And at the C-Prompt clinic, they offer urgent assessments, medication support, short-term psychotherapy, which is a maximum of 4 sessions per client, and help with accessing other services as required. So we will put up the resources that you listed, and I'll also provide the link to the C-Prompt clinic.
Thanks so much, Nancy. And as I understand it, that wait list is very, very short at this point. Am I correct in that?
No.
Okay. All right. Well, we can verify that. I thought you might know better than I do, but my understanding is that it's a short wait list to be seen there. So that's an amazing resource through the Royal. Thanks so much.
Thank
you. Okay, so let me talk a little bit more broadly about actual treatment of depression and anxiety and what that may involve. So when we are looking at mild to moderate depression or anxiety, our treatment of choice is really psychotherapy. So psychotherapy refers to talk therapy, where you are meeting virtually even with an individual therapist or perhaps in a group format. and you're working on specific goals. So there's different types of psychotherapy, and we use different types of psychotherapy to help us with different kinds of goals. And I'll go through the different kinds of psychotherapies because I think it's useful. When people think of therapy, if you're not familiar with it, it can be sort of very nebulous and not easy to understand how it may be of help to you. So I'll take a bit of time to go through the different types of psychotherapies and increase your knowledge about what may be helpful to you. So the most common type of therapy that we hear about is CBT, or cognitive behavioral therapy. The basic premise of cognitive behavioral therapy is that when you are, for example, clinically depressed, the disease changes the way that your brain thinks. So the way that your brain thinks when it's clinically depressed is that everything about the present is negative, the future is bleak and holds no hope, and nobody understands you. Lots of negative cognitions. And buried under those negative cognitions are a lot of assumptions. And the understanding is that when you're clinically depressed, you just don't have the mental capacity to work through some of those assumptions and those viewpoints very quickly. And so that affects your behavior then. Similarly, for anxiety, you may be operating, when you're suffering from clinical anxiety, you may be operating on a lot of different assumptions that lead you to worst case scenario thinking or black and white type of thinking without the flexibility. And that's what the disease takes away from you, is the flexibility to problem solve as you would when you are well, or to think about other possibilities or different ways of looking at things. And so cognitive behavioral therapy really forces people to slow right down and break down those thoughts into little itty bitty micro thoughts. And so that you can challenge a little bit more mindfully each of those micro assumptions and micro thoughts. When you break it down that way, and when you do it a little bit more slowly, it's much easier to think of alternatives, particularly if you're working with a therapist who can, help you to brainstorm around that. And then once you've broken down some of your cognitions, that gives you the opportunity to maybe make different choices. Again, a little bit more mindful choices about the thought train that you're going to take. What you'll work on in therapy is behavioral experiments, because it's very easy to say all of this and it sounds very logical, but if it was that easy to do, then you would be able to do it on your own. And the whole point in a clinical depression or a clinical anxiety episode is that it becomes very difficult to do that on your own. And so along with the coaching with a therapist, you'll work on slowly making decisions in real time in your real life, where you actually get on a thought train that leads you to a healthier place and to better coping strategies. So that's CBT. CBT is offered in many, many different formats. You can have extensive CBT. The typical course would have been 16 sessions of 1 hour each. We definitely have a lot of evidence that even shorter lengths of therapy can be effective, 10 sessions. For example, the C-Prompt clinic, is offering potentially up to 4 sessions. We also have the Big White Wall, and the Big White Wall is sort of based on, and the therapy programs that you can launch from there. Bounce Back is a free cognitive-based therapy, which is offered through the telephone. Again, much shorter, sort of 4 to 6 sessions of about 20 minutes each on the telephone. And that's based on cognitive behavioral therapy principles. So smaller doses can be extremely effective, especially if your symptoms are milder. So that's CBT. I'll move to a different kind of therapy called IPT, Interpersonal Psychotherapy. That's something that we do in our perinatal program at the Ottawa Hospital, which is accessible by referral through any physician, midwife, nurse practitioner who is associated with the Ottawa Hospital. They are all able to submit referrals to our program directly. And one of the things that our program offers is the interpersonal group therapy. We offer it in a group format, but it can be done in an individual format. So I explained the basic premise to you just now of CBT. Now I'll explain the basic premise to you of IPT. So IPT is works on the assumption that as human beings, we are social creatures. We are not meant to be raised in isolation or live in isolation. And I think that's something that we're all experiencing right now. We're herd creatures, right? We're not like baby fish where, there's 10,000 eggs laid, and if 3 survives, that's amazing for the species. We have only 1 child, 2 child at a time. We take a lot of care to nurture them into adulthood. And those children, they are not independent. They need a herd, they need a family and positive social connections to not only survive, but also to thrive. And so if you put a human being in a place where their social connections are threatened, that could expose them to poor health. So just like if you had not enough water, you would get dehydration, or not enough food, you would get malnutrition. If people are subjected to a real change in their social situation where they are not supported and they're not getting their emotional needs met, they could succumb to clinical depression or clinical anxiety. And so what we work on in IPT is looking how to improve your social connections and your social supports. So we're not looking to make you social butterflies. What we're looking to do is to look at how your social structure may have changed. For example, are there people in your life that you should actually be getting a lot of support and reciprocal emotional exchange with, who are just not there for you? Typically in this perinatal period, it's about couple conflict with the other parent of the child, maybe conflict with grandparents and in-laws, or conflict in the workplace as you leave that work position that you were in before. And so people that should have been supportive to you, if they're not, that can leave you vulnerable. Also the transition of welcoming a new child into your family, whether it's your first, second, third, each child makes it a different family experience and changes the family dynamics. And, even though it may very well be a wanted change, and sometimes it isn't, but even in the case where it's a wanted change, it's a change nonetheless that could change your social structure and therefore erode the number of social supports that you have access to. So in IPT, we're looking at, again, improving those supports. The problem is that when you're clinically depressed, when you're clinically anxious, you're sometimes at your worst in terms of trying to communicate your needs and get the support and the help that you need, because that's the nature of the symptoms, right? When you're clinically depressed, you might be really irritable. You just might not have a lot of energy to reach out to people. It's all you can do to feed your kids, and maybe if you're lucky, feed yourself and pick up the toys at the end of the day. But to actually call a friend is sort of not within the scope of what you feel up to doing. In terms of, so that's what we work on in IPT. Group therapy is another option, which is, I think, a very powerful way of doing therapy. So it's one thing to work one-on-one with a therapist. When you work in a group setting, you not only get the feedback from often co-therapists, because we often run groups with 2 people facilitating the session. But you also get feedback from the members of the group. And to get feedback from your peers is actually an extremely powerful experience, because you're getting feedback from people that are going through the same experience or very similar experience to what you're going through. And they're able to relate, they're able to empathize, and they're able to show you blind spots that you may not have realized. That can be extremely powerful. It's also very powerful to watch your peers as they take on their challenges and work through the issues that they're working through, and you can learn vicariously through them. So I know a lot of people, when I mention, hey, we have this amazing group over here, is this something that you're interested in joining? They kind of hesitate and say, I don't know about that. But I'd encourage you to think about the group therapy. It's a very, very powerful experience. The other kinds of therapies that I'll mention quickly are couple therapy and infant therapy. So couple therapy, I know that, there's lots of sort of lay knowledge about this. I would emphasize that if ever there was a time for you to look at your relationship and make a tune-up, even if things are going well, it would be around the time that you're having children, whether it's the first child or a second or third child. Each birth brings new challenges. And as I said before, those transitions can be really tricky to overcome. Sometimes it's really hard to know what's going on in your partner's brain. And it's hard for them to know too, because you guys are just really trying to put one foot in front of the other and make it hour to hour, let alone day to day, especially if you're stuck at home with an infant and toddlers in a pandemic and you can't go anywhere and you can't get supports that you're usually used to getting. So couple therapy is a really important tool. And, for those of you who've been able to capitalize on it, congratulations, and please spread the good word to other people, because I think a lot of people underutilize that. I'll mention that for women suffering from postpartum depression and anxiety, the risk is of 1 in 5 mothers having babies. It's actually also 1 in 10 dads having babies that can also suffer from depression and anxiety. So, thinking about your partner's mental health as well, and that may also be impacted by having a baby, and that might be at the root of why you guys are having issues. Infant therapy is the last type of therapy that I'll briefly touch on. Infant therapy is geared towards strengthening the attachment between a parent and a child. So usually a child under the age of 3. It's really important. That's, sort of the ages between 0 and 3 are when our experience in life really lays the foundation for future relationships that we engage in and our worldview. So if we grow up in an environment where, our parents are doing as good a job as they can, it doesn't have to be perfect. In fact, perfection is probably unhealthy for children. But if parents are able to often enough anticipate their child's needs, meet their child's emotional needs, understand their child's emotional experience, that leads children to grow up with a sense that they're valued, that it's worth connecting to people in their lives. Relationships are important and a way to help them resolve difficulties that they may be going through. And that's the skill that they take with them into adult life, and helps to protect them from future mental illness. So developing that strong attachment bond is really important. And there's some really great organizations offering an intervention called Circle of Support. My gosh, I think I'm blanking on that. Nancy, do you know if I'm saying that wrong? Okay, it'll come to me if I'm...
I know there's something, I think it's Circle of Security.
Circle of Security, thank you. That's right, that's what it's called. So Circle of Security. And that is being offered through various community organizations. CHEO is offering one virtually, and in typical times, I know that a lot of the community agencies like the early years centers would be other places that offer the circle of security intervention. And that's meant to improve attachment between parents. And it's not just mothers, it's for fathers as well. So parents with their young babies and toddlers. So that's my spiel on psychotherapy. Again, highly effective. The data shows a great deal of efficacy and also personal growth, sustained personal growth from doing good quality psychotherapy, especially for mild disorders and into the early moderate zone of severity for depression and anxiety. I'll take a pause there and see if there's any questions that Stephanie's been able to collate.
Perfect timing, because we just had one come up. Question is, has infant therapy been used in helping mothers who suffer from severe postpartum depression or postpartum psychosis connect with their children again?
Yes. Absolutely. That's why it's so important. So, I only talked about therapy for mild disorders. When you have severe depression and you have psychosis, you have to get back to a place where your brain has the biological capacity to do therapy, right? So first things first, we can't really work on the relationship with a baby if your reality is currently distorted. We have to address that first. So once the psychosis has resolved, once the depression is back into that mild zone, absolutely, that's the next step, is to look at the bond. Often the bond does improve and doesn't necessarily need any intervention, but if there are ongoing difficulties with attachment, that would be the time to implement the circle of security as a first step. And then if there are ongoing issues after circle of security, then it would be talking to your family doctor about what next steps might be. Any other questions, Stephanie?
No other questions at this moment.
Okay, so I'll move around now to medications. And, just want to emphasize that I'm going to give you general principles of using medications during pregnancy, some of the risks at a higher level, and also during breastfeeding. But, really want to make it clear that full medication discussion is something between you and your care provider. And I can give general principles, but actual decisions are going to be related to your personal history, your health history, your family history, your current symptoms, and even your environment that you're in right now, what the supports are right now. So with that caveat in mind, let's take it away. So when we look at the safety of medications in pregnancy, I'll start in pregnancy, we look at a couple of different things. So we look at, does it affect your capacity to reproduce? So for women, does it affect ovulation or eggs, the quality, the nature of the eggs in any way? For men, does it impact on their sperm quality or their sperm production? And in general, and I'm only going to focus on antidepressants in this discussion. There are many different medications that we use in psychiatry. In general, antidepressants don't seem to have an impact on reproductive potential for either males or females. The next question that we ask ourselves is, if a pregnant mother is using this medication during her pregnancy, will that impact the baby's development in any way? So now the important thing to know about baby's development in the belly is that its organs are mostly forming within that first trimester. In fact, a lot of the a lot of the important fundamental work gets done even within that first 8 weeks in terms of the neurological system being developed. So once you get past that first trimester, the organs are set, the organ systems are set, and the rest of the pregnancy is a matter of growing and maturing to the point where the baby is able to survive outside of the uterus on its own. So what we're really looking at in medications is, do they impact that first trimester? Do they interfere with the development of the organ systems? By and large, most of our antidepressants actually show no increase in birth defects in the first trimester. So again, that's a very broad generalization, but you should feel very reassured that by and large, antidepressants do not need to be stopped in pregnancy. Whenever we counsel women about the use of medications in pregnancy, we always ask them to look at, well, listen, you can't look at the risk of a medication without asking yourself, what is the risk without using medication, right? Because it's a relative thing. It's not an independent question. Obviously, the best case scenario would be if there was no depression, no anxiety, no disease, and no need for medication, and you could have a pregnancy without disease or without medications. So, but unfortunately, we don't choose disease, right? Disease happens, and to a large extent, that's really just completely out of our control. So when disease happens, now we have to ask ourselves, okay, what's at higher risk here for both mother and for the fetus? Is the higher risk having exposure to disease, or is the higher risk having exposure to medication? Okay, so I talked about the first trimester risk of most antidepressants. Without antidepressants, for every 100 babies that are born, 2 to 3 of those babies will have some kind of birth defects. That's just our human genetics. So when we look at birth defects, we need to look at, is there an increase in the 2 to 3 out of every 100 births that we see? And that's where we see, no, there really isn't for the vast majority of antidepressants. Again, there are specifics that you need to talk about with your healthcare provider, but by and large, we don't see a change in the birth defects. And also, we don't see a change in the growth of the babies over the second and third trimester and the maturation of the organs there. We do see that there is a risk of being exposed to untreated disease, and that could be difficulty with fertility, so difficulty conceiving, difficulty maintaining a pregnancy once conception occurs. We do see that there can be some increased risk of prematurity in severe cases, as well as an increased risk of deliveries that require an intervention, whether that's like forceps or like an outright C-section. We see a higher risk of that in women who have been suffering from depression and anxiety throughout their pregnancy. So there are good reasons to treat, especially if you're on a treatment which is already effective and you have no side effects to begin with. So that's a bit of that risks and benefits conversation that we like to have with women when deciding whether they should continue with their medication or not. The one thing that I will impress upon you is that if you make the choice to continue with your medication, make sure you and your prescribing care provider are choosing the optimum dose of that medication. I know a lot of women will say, well, I think I could get away with just like, a baby dose, like it just takes the edge off of the worst of my anxiety, and I won't risk the baby getting exposed to more medications. We don't have that data to back that kind of a decision. We don't have the data that says, as long as you're within the therapeutic range, that half the dose is somehow less risky to your baby than a full treatment dose. So if you choose to use medication, make sure that you're using a therapeutic dose. That's all I wanted to say about medication in pregnancy. I'll take a quick pause just to see if Stephanie has any questions for me to answer before I go on to delivery and breastfeeding with medication.
No new questions have come up recently.
Okay. Alrighty. So one of the risks of using antidepressants is that the baby will experience withdrawal after it's born. We call this PNAS, or Poor Neonatal Adaptation Syndrome. So let me start with what withdrawal looks like in adults. So for any adults in the audience that may have used antidepressants, you're usually counseled that never stop them cold turkey. If you need to come off, always do it with the guidance of a physician on how to slowly taper your medications. And the reason for this is that if your body is suddenly deprived of the antidepressants, you can actually experience a withdrawal syndrome as an adult. As an adult, what that looks like, it's a bit of you feel terrible. You feel like you've got the flu. You've got aches and pains all over your body. You're fatigued. You may be nauseous, headaches. Some people complain of brain zaps. It can be quite uncomfortable depending upon the antidepressant that you're using. That's not the case if you taper down slowly off your antidepressant. And for some antidepressants, the taper needs to be a bit slower than others. The thing is, for babies, when they are delivered, it's like they're getting abruptly cut off of antidepressants. So anything that you take during your pregnancy, it will pass through the placenta and it will go through the circulation of the fetus, right? All of a sudden, the fetus is delivered and it no longer has access to the maternal blood supply. And therefore, there's no more exposure to antidepressants. And so the baby's put in the position of being suddenly taken away. And the PNAS symptoms in infants they are not as dramatic as they can be in adults. So babies tend to be a little bit more irritable, a little bit more fussy. They're a bit tremulous. Babies are born with special reflexes called neonatal reflexes. For example, if you stroke their cheek, they'll turn to that. Or if you put something in their mouth, they suck on it. Those reflexes can be a little bit diminished. Their breath might be a bit jagged and irregular. Usually it lasts only a day or two, and then it goes away completely. And we have data looking at, sort of 5 to 6 years of age, and we don't see any negative side effects from that withdrawal. It really does appear to be a withdrawal type syndrome. In really severe cases, because everybody goes on Google and looks at what the worst case scenario is, in really severe cases, you can have babies not just having tremulousness, but actual outright seizures. And instead of just irregular breathing, having breathing difficulty. Those are really, really, really rare cases. I've been doing this for well over a decade. We see about 300 women a year. I've had less than 5 mothers whose babies have had those extreme withdrawal. And they were moms who, even as a perinatal psychiatrist, I was very nervous about the medications that I had to keep them on because they were extremely high dose, multiple different medications, not just antidepressants. And they would have had to been hospitalized if they weren't on the medications that they were using at that time. So that is not a typical, even though you will find that on Google, it is by far and away an extremely rare circumstance. The incidence of the low level, more garden variety type of PNAS or neonatal withdrawal is about 1 in 10 babies experiencing some withdrawal. And I like to warn my moms about that too, because when babies are born, their health is fragile, right? If there's issues, if there's clinical concerns, the care providers at that time need to react quickly. So they will work up a baby for, things like infections or genetic disorders or seizure activity, they will make sure that those are not what we're seeing before they will rest and say, no, this is withdrawal from antidepressants, because that's a diagnosis of exclusion. The worst thing would be is if they missed, some kind of infection and they said it was withdrawal and it really wasn't. But it can be anxiety provoking to have your baby be worked up for something. And that's why I always give moms and dads a warning about that beforehand. So, really the withdrawal is the major risk, but it's a low chance of happening. It's only 1 in 10 babies. The babies experience discomfort for a day or two, and then they're finished and you move on. And for that price to pay, the baby has not been exposed to your disease, to the clinical depression or the clinical anxiety during the pregnancy. In most cases, that's a reasonable price to pay. Generally speaking, again, most antidepressants, and again, these in general terms, are not excreted in significant quantities in breast milk. So once you've delivered your baby, for most antidepressants, the medication is no longer pertinent to the baby. So the general rule of thumb for any medication, whether it's an antidepressant or an antibiotic in lactation, is if it's excreted less than 10% into breast milk, then it's considered safe for baby. And like, if you think about it, like if you had 1 liter of milk that the baby was drinking from and 10 milliliters of that contained the substance. So when the baby drinks the milk, not all of those 10 milliliters of substance are going to make it through the stomach. Only a portion of that is going to actually be absorbed into the blood. Whatever does get absorbed first has to go through the liver, where it gets cleaned even further. So some of that will also get rid of it. And then even more so for antidepressants, there is a blood-brain barrier, which is another barrier that's very difficult to cross. So even of that little piece that got through the liver, even less will actually get through to the brain. So even if you started at that 10% excretion rate, which is our limit, by the time you get active medication that's operating on the baby's brain, it's next to minimal. So by and large, lactation during breastfeeding is reasonable to do. I'll pause there to see if I have a few other thoughts that I'll share with you, but before I do, I'll ask Stephanie if there's any other questions.
No new questions.
Okay, you guys are an easy audience. So, I get a lot of questions when I see women in consult of, well, what if I just skip the first trimester? I'll stay off of my medications for the first trimester. That way I know 100% that the baby is safe, and, I'll start up again in second and third trimester. And again, certainly that may be an option for some women. I tend to counsel against that for a couple of reasons. So a lot of the times when women come to me, or when they come up with that idea, they are already a couple of weeks pregnant, usually around 7 or 8 weeks pregnant. So by that time, a lot of the first trimester is already over. So, and especially the neurological system, the foundation for that one has already been laid. So you're not really saving your baby a ton by stopping medication once you've noticed your pregnancy, and once you realize that you're pregnant. You're not saving your baby a lot, and you're also exposing your baby to potential recurrence of disease. So, if you get pregnant and you're on your medication, definitely talk to your care providers about the safety of that medication. But if you are counseled that, it's a reasonable medication to continue, you just keep that in mind, even if you're still feeling discomfort about continuing it, that you're not necessarily saving your baby anything. You're actually maybe risking them being exposed to disease if you stop medication prematurely. If you are worried about medication before you conceive, it's definitely always an option, of course, to slowly taper down your medication so you don't experience any withdrawal. But again, we all wish it worked like clockwork, but you don't always get pregnant exactly when you plan to get pregnant. So, a typical weaning off of your own antidepressants could be anywhere from 2 weeks to a month. And then, it takes you however long to actually conceive. And then at that point, you're maybe looking at the first trimester to stay off of your antidepressants. So another 3 to 4 months there. So you could actually be looking at a really, really long time off of your antidepressants by the time everything is said and done. And that is a good amount of time for your symptoms to come back off of medication. So again, risks and benefits. Yes, you'll save your baby the exposure to medications, but will you save your baby the exposure to disease? And that's kind of an individual conversation that you'd need to have with your care provider on that. Another common question that I get is, okay, well, what if I start to wean down or stop my antidepressants in the 3rd trimester so that the baby doesn't go through withdrawal? And it makes sense. Like, I can understand why people would ask that question. The thing is that, first of all, if you stop your antidepressants in the 3rd trimester, cold turkey, babies can definitely experience withdrawal in utero. You just don't see it in front of you. We do see it, though, if you monitor them with ultrasounds. You can see evidence of the baby's heart rate and discomfort and increased tone in utero. So it's just not something that you can see if you stop abruptly while you're pregnant. If you go down gradually, again, the issue is that you're protecting your baby from the potential of withdrawal, but you may be increasing the potential for you getting sick. And if you look at the year in which you're pregnant and the year after you've delivered, you're at high risk for your anxiety or depression coming back during that time. The highest risk period is in that first month or two postpartum. So if you've stopped, first of all, we can't also predict when baby is going to come. So you have to kind of choose what date you're going to stop. But, maybe you're giving yourself a little bit of leeway. So you're stopping at about 8 months pregnant, or 36 weeks, you're starting to wean down, but baby doesn't get born until 41 weeks. And then, then you have to restart your medication. So, it takes a couple of weeks to get back on the right therapeutic dose. And as you know, antidepressants don't work right away. They take 4 to 6 weeks at a therapeutic dose to have their maximum impact. So by the time everything's said and done, it's another 2 to 3 months before you're back on your therapeutic dose, experiencing the therapeutic impact of your medication at your most vulnerable period in time. So, again, different women, different families will decide in different ways that make sense to them based on their personal circumstances and their personal history. But it's not always a clear-cut answer that it makes sense to stop beforehand. I'll pause there. Stephanie, are there any other questions that are coming up right now?
No new questions.
Okay. I'll end off with a few non-medication things that you can do, lifestyle interventions that actually have evidence behind them in terms of what works. So the number one intervention that will work at a biological level is protecting your sleep. We have really strong evidence that 5 consecutive hours of sleep can actually prevent somebody who is at high risk of developing a depressive episode. It will prevent that from happening. And that's easy to say, 5 consecutive hours of sleep, but maybe practically hard to do when it comes to a newborn baby. So, something I always talk about is who's in your support circle. Is there anybody that can support you to feed the baby, to stay up with the baby? Even if you can't get those 5 hours overnight, are there other times during the day where you can get 5 consecutive hours? Because in those first few weeks, anyways, your circadian rhythm is all thrown out the window. So you may as well get the sleep when you've got the support. If you're a 2-parent family, sometimes what works well there is the mom sleeping from 7 p.m. to midnight, and the second parent sleeping from midnight to 5 a.m. Again, the other parent is also at risk for their own depressive illness, so we want to protect them as well. And that sets up the other parent who is maybe not on a leave to go to work to have more of a regular cycle for a work day. And it's not that each parent doesn't get to sleep during the shift where they're on, it's just that that sleep is interrupted during that period of time. So that's something that works really, really well for a lot of families that can manage that. So apart from sleep, nutrition is extremely important, and it's very, very easy to forget about feeding yourself, especially in the chaos of having a new baby, and all the demands on your time. If you've got a toddler running around at the same time, a lot of women will focus really, really hard on the nutrition of their children, but not actually feed themselves very properly. Back in the days when we used to fly, remember those times a couple of months ago, the airline attendants would always give us the talk at the beginning of the flight to say, if the masks come down, be sure to put your own mask on first, your own oxygen mask, before you help the people around you, the dependents around you, because you won't be any of help to them if you end up passing out. And the same is true during your postpartum year. If you are not nourishing yourself, if you're not taking time to support yourself, to rest as much as you can, you're not going to be of great use to the people that need you very much. So, getting over some of that guilt of being a mom and always being there for your children, the time that you take for yourself, to feed yourself, to nourish your soul, to get support from other people, to sleep, that is time spent on your children just as much as it's time spent on you. You will become a better parent for that time that you spend. So I'm just keeping my eye on the time, and I see that we've got 1 minute to go. So I'll stop again and just see if there's any other questions or anything that comes up at the end.
No new questions at the moment.
That was very thorough, Dr. Gandhi. That's the reason why I think there isn't questions. Usually what happens is we have a lot of people that watch the video after the presentation. So sometimes there are questions that turn up in the comment section afterwards.
Absolutely. And feel free, Nancy and Stephanie, to reach out to me, and I'll do my best to support you guys in answering some of those questions. So
thank you. So
please.
I wanted to sorry.
No, I was going to ask people in the audience to please do ask your questions.
So I wanted to clarify about the C-Prompt clinic. So I reached out to one of my colleagues, and they let me know that there isn't a wait list for that program. And also the psychotherapy that I mentioned, that's up to 4 sessions, is CBT based. Yeah.
Terrific. That's terrific. Encourage you all, if you're that's such a tremendous resource, and kudos to our colleagues at the Royal for throwing that together. It's not an easy program to create.
So if people are interested in accessing that program, they can talk to their healthcare provider. And if they go to the Royal's website and look under C-Prompt, there's a referral form that your healthcare provider needs to fill out and then send to the Royal. So I wanted to thank Dr. Gandhi. That was a really fantastic presentation. There was a really great balance of clinical and non-clinical supports for people with postpartum and perinatal anxiety and depression. I'm also watching the time, but I do want to remind people that there are other Facebook Live talks. We have a talk about perinatal mood and anxiety disorders with Dr. Giroux. There's another Facebook Live talk about pregnancy, birth, and breastfeeding during COVID-19, and that's with midwives Teresa Bandrowska and Nicole Pichette. And there's also a wellness talk with Anne-Marie O'Brien and Emma Slanley-Gose. So thank you again, Dr. Gandhi. It's always a pleasure to see you.
Likewise. Best
Thank
wishes to
you.
all parents in the audience. Thanks, Stephanie, for the support.
It was great. Thank you.
Thank
Have a
you.
great day to you both.
Yep, you too.
Bye.
Bye, everyone.
Stay healthy.
Bye.